Welcome, everyone. We can go to the next slide. So happy to have all of you with us. I'm Jessica Gonzalez, a coordinator with the Mental Health Technology Transfer Center Network, and I'm excited to co-facilitate today's session. Thank you for joining our conversation today on culturally responsive, evidence-based, and community-defined practices for mental health. This listening series is a 6-part series that's being led by the MHTTC Cultural Responsiveness Working Group. And today's session is the first session of the series that's focusing on setting the stage for the remaining listening sessions. We're so excited to have a lovely conversation with you all after I've gone through a few housekeeping items. Next slide. We want to let everyone know that we have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. And the session today is being recorded and it will be posted on our series webpage within a week. And you will also receive an email within a week with today's session recording, the slide deck, and information on how to access a certificate of attendance. A reminder that if you have audio or technical issues during the session, the chat box is open for you to communicate with our team so that we may assist you. If you have any resources that you'd like to share with the other attendees, you can enter those in the chat box as well. If you have any questions for the presenters, please enter those in the question and answer pod. We have our lovely working group co-chair, Christina Clayton, monitoring the Q&A pod. And so she will ensure that we address your questions throughout the session. We also have scheduled plenty of time for a Q&A portion with our guests today towards the end of the meeting. And so please feel free to submit your questions at any time throughout the presentation, and we'll try to get to as many as possible. A quick reminder that we also have closed captioning available for today's session. For those who would like to enable or disable the closed captioning, please click on the CC button on the bottom of the Zoom platform for options. Now, I also want to remind everyone that you all are muted and cannot share video except for our panelists and facilitators. So you might be wondering how we plan to have you all converse and engage with us today. So just letting you know, we will be using Poll Everywhere to gather your comments throughout the session. Next slide, please. For those who are not familiar with Poll Everywhere, this tool allows us to share a live poll with everyone in the audience. And you can easily participate by following the steps on the screen. We'll be adding the information to the chat box in a little bit. And I'd like to give everyone a minute to either open up your web browser and get logged in to Poll Everywhere, or you can use your phone and text your way in. If you have any issues getting in there, you can go ahead and enter any questions in the chat box, and we'll be happy to assist you. Just gonna give it another minute. I've put the link in the chat box there for you all to click on to get into the Poll Everywhere platform. If you prefer to text your way in, I'm putting in that information in the chat box as well. In the meantime, while you all are getting signed in, I will go ahead and start with a very quick overview of the MHTTC network. So again, welcome. If you're new to us, this is a 6-part series that is a collaborative effort of the Mental Health Technology Transfer Centers, also known as MHTTCs. We're a network that's funded by SAMHSA, the Substance Abuse and Mental Health Services Administration. And our network includes 10 regional centers, a National American Indian and Alaska Native Center, a National Hispanic and Latino Center, and a network coordinating office. Our collaborative network supports resource development and dissemination, training, and technical assistance for the mental health field. Next slide. After today's session, we suggest that you visit our website and find your regional center to keep in touch with us for more resources and training opportunities, which are all free of cost. Next slide. And as part of receiving SAMHSA funding, we are required to submit data related to the quality of this event. And so at the end of today's training, we ask that you please take a moment to complete a very brief survey about today's session. All of you will be automatically redirected to the survey upon closing the Zoom platform window. And just a really quick disclaimer, this presentation was prepared by the MHTTC network under a cooperative agreement from SAMHSA. And the opinions that are expressed in this learning session are the views of our facilitators and panelists and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. Okay, well, I think we're ready to officially get started. Thank you so much for your patience as I went over those reminders and housekeeping items. Again, this is session 1 of the listening series focused on culturally responsive, evidence-based, and community-defined practices for mental health. This series is being led by the MHTTC Cultural Responsiveness Working Group. And to share a little bit about our group and why we are putting on this series, I'm happy to introduce you all to our group co-chair, Maria Restrepo Toro. Thank you so much for being with us, Maria. I'll pass it on to you.
Thank you so much, Jessica, and welcome everybody. It is our pleasure that you're joining the conversation today. So what is the Cultural Responsiveness Group? We are a collective group of individuals across the network who came together at the beginning of the Mental Health TTC when we all started to do this work. And really our mission is to identify and create new resources that are going to be supporting the entire network. We name ourselves Cultural Responsiveness for 2 reasons. The first one is we really believe that in all the products and disseminations we do, we want to create cultural awareness, cultural knowledge, and also create some skills that we can share with all of you. A second part of that important name that we chose is about cultural inclusive language. And next slide, please. So our group was actually created the Mental Health TTC, affirming respectful recovery-oriented language. We do know that as a network, when we use first-person language, we inspire hope, we uplift recovery, and we acknowledge that every person has their own unique strengths. Therefore, we are really, in all the activities that we do, we convey respect, we are sensitive to difference, and we avoid any images or promote any biases that are going to promote a stereotype. So throughout this session, we invite you to also compile to this language. Next slide, please. So how we got here today? So as I mentioned before, our group started from the beginning of the network, and immediately we got together and we decided to really form this fantastic group to aim and to really disseminate cultural appropriate information. So to accomplish these things, we really did 2 very important efforts that are actually very important to set up the ground for these listening sessions. The first one was to really create a directory across the network of experts in multiple languages, multiple topics throughout the network that you could have access on our website. We create a fabulous web page that you can access as well through the NCO office. And in addition to that, after we did a survey, we decided that it was very important for us to really understand evidence-based practices when it comes to really different communities of practices. And we created this amazing chart that really identified, but immediately we realized that there are 2 processes that are important to understand. We know that an evidence-based practice really integrates the best research with clinical expertise in the context of the individuals, but we also discovered that there are very community-defined practices that have been used by community, inform the community, provide positive results, but may not be measured. Therefore, our group decided that the next step is what we're actually here to do today, is get an understanding from all of you around these topics. And we found a fabulous network and a fabulous panelist for today. So what are our goals for today? Next slide, please. So the goals for this sessions then, as Jessica says, there's 6 sessions. Today, we're only setting up the stage. Before, the first one is to really create an interactive conversation. This is why we're using poll everywhere. We wanted to use the chat. We need to learn from you so we can help you in this very important process. We also want to explore strengths and barriers in all those community-defined practices so we can then elevate all the cultural linguistic appropriate services standards that we are going to be hearing from one of our panelists today. And that's why we are doing, then after all this information, we're going to collect the information we receive from you, and we want to be including and promoting the evidence-based practices and the community-defined practice across our network. So the agenda for today goes as follows. Next slide, please. First, I think we're going to hear from our wonderful expert on evidence-based practices, and she has actually worked with her. I will introduce her in a moment. Then we're going to have a conversation about the CLAS Standards, an overview from one of our group members. And then we are going to have a conversation that's led with my fabulous co-chair, Christina Clayton from Region 10. So Jessica, let's go back to the next slide, please. Going back to you.
Great. Thank you so much, Maria, for that wonderful welcome and orientation. Okay, everyone, get ready for a poll coming up next. We're adding the instructions on how to join in the chat box. The instructions are also up on the screen. I think that the easiest way for you to join is to open your browser to the web link that we've inserted in the chat box. Or if you have your phone readily available, you can text NW-MHTTC to the number 22333. Again, we have the information up on the screen there. I'll give everyone another 20 seconds to get logged in. Everyone, please try using the link that we've inserted in the chat box. I see in the Q&A pod, someone said that their browser is not supporting the Poll Everywhere link. I'll insert it in the chat box again. Everyone should see it there. It should be live now. I think we'll go ahead and get started with our first poll. So how familiar are you with the term evidence-based practices on a scale of 0 to 5? 0 being not familiar at all, and 5 being very familiar. Wow, it looks like the majority of our audience today is saying they're very familiar with evidence-based practices. That's great. We also have some in the middle there. A couple who are not familiar at all. Great. It looks like the majority of our audience is very familiar, so that's awesome. We have a lot of 3s and 4s as well. This is great. Thank you so much, everyone, for participating. We do have several more polls throughout our presentation, and so now that you all are logged in there, I'm glad that it'll be a seamless process for you. And if you weren't able to get in, please do let us know in the chat box and we'll be happy to assist you. Let's go ahead and close this poll. It's great to know who we have in the audience to have our first speaker get a really good understanding of who's joining us today. Okay, Maria, I'll pass it on to you so that you can introduce us to the wonderful Shannon Wilsey Sturman.
Excellent. Thank you, Annie. Wonderful. I can see there's more people joining. So welcome everybody if you just joined it. We're about to start our conversation. And to do that, we have the honor to have and welcome our first panelist who's going to be setting up the stage, Dr. Shannon Woolsey-Stearman. Next slide, please. Shannon has actually been a consultant for our group early on, and she is a clinical psychologist and implementation researcher in the Dissemination and Training Division. She's also an associate professor at the Stanford University Department of Psychiatry and Behavioral Sciences. Her clinical work and research focus on training, implementation, and adaptation of cognitive behavioral therapy for individuals with PTSD, depression, suicidality, and anxiety. She regularly provides CBT and cognitive process therapy training and consultation to therapists in the community and in the VA. So it is my pleasure to welcome Shannon to our conversation to set up the stage. Thank you for being with us.
Thank you very much for having me today. We can move to the next slide. Great. So it sounds like people are pretty familiar with the idea of evidence-based practice, based treatments, et cetera. So I'm going to just talk a little bit today and make some distinctions. And really these, I think, are intended to be kind of a starting point. These are some of these are commonly accepted definitions, and some of them there's maybe a little less consensus around. But we can use these as a jumping off point and certainly discuss whether and to what extent they really fit with your experiences in the settings where you're working. So evidence-based treatments are treatments that, that we have some evidence can work. And that is based on both research support and also evidence of effectiveness in the community. Next slide, please. And so we know that behavioral health practices can fall somewhere on the spectrum of harmful to effective. And, you know, in the middle, we also have things that we don't know much about. Either it's very new and still being kind of developed and refined, or we're gathering evidence on it. Promising might mean that we've got some evidence that it's effective, but not enough to sort of universally say that, you know, that we have a sense that it's effective. Next slide, please. Okay, and then evidence treatments, when we about specific treatments that we are calling evidence-based, means that they're tested in well-designed studies and compared to other treatments. So we know that it works, and we know that it works well as established treatments and maybe is a better fit for some folks, or better than established treatments, in addition to being more effective than nothing. You know, we see if there's a reason or an advantage to using this or something else. And ideally, they are shown to be effective in improving the kind of the target problem, you know, the symptoms, the problem that they were designed for, and then also that translates into people's lives improving as a result of the treatment. Very often they set specific goals and track progress. And there's a clearly specified underlying theory that guides the conceptualization and the treatment. Next slide, please. Now there's also, and I think there are a couple of animations here, there's also the American Psychological Association's definition of evidence-based practice. And this is based in part on the Institute of Medicine's, that it's an integration of the best available research evidence with clinical expertise and context of patient or client characteristics, culture, and preferences. And this has been conceptualized as a three-legged stool. And I think what's important here is that we want to make sure that we're not leaning too hard on one side of the and becoming unbalanced. that means not leaning too hard on the research evidence where it might not be as effective for specific populations or for people with specific backgrounds and experiences, that we're not leaning so much on our clinical that maybe not focus on, the research evidence is saying, and also that, we need to integrate what we know from our own experience, from our own practice, and from the research evidence into what we're hearing from our patients or clients.
Sounds like we're having some difficulties with Shannon's internet. Let's wait for a moment to see if she can reconnect. Shannon, could we? There you go. Now we hear you.
Sorry about that. It always makes me the heart of Silicon Valley when my internet freezes. Yeah, so we basically want to make sure that we are keeping the stool balanced and really attending to all three of. This is for any form of evidence-based practice, no matter what underlying intervention you might be using, to all three of these things. Next slide, please. So it's become important too to consider community-defined practice, community-defined evidence. And at the bottom, there are links to a couple of nice resources for community-defined practices, community-defined evidence. But these sort of come through, they're complement to evidence-based practice. And they are, the evidence that people attend to is not only the research evidence, but also of effectiveness in communities. So they're practices that communities have used and found to yield positive results. These positive results are determined by consensus over time, and that's by attending to outcomes that are important to the stakeholders in that community. The practices may or may not have been measured empirically, but they've reached a level of acceptance within the community. And they integrate that population's worldview and the social context, the historical context. So, as I mentioned, this is considered to evidence-based practice. And there are many community practices and community-defined evidence that have emerged over time. And often what we kind of do in partnership is kind of use these two kind of traditions to complement each other, and to do that in a way that is in the best of the populations that we're serving. Next slide, please. So I want to provide some definitions for cultural responsiveness and inclusiveness. And these are actually definitions that are maybe a little bit less established. So I say that because there are fewer, publications and places that actually provide working or operational definitions. Sometimes these might be things that, you know it when you see it, and the terms are used frequently, but they haven't been, as clearly defined as widely. So there is a definition for cultural responsiveness or culturally responsive counseling, suggests that it includes three components: cultural awareness and beliefs, that it's sensitive to the personal value, the personal values and biases, and how they might influence their perceptions of the clients, the way they think about the client's problems or challenges, and the therapeutic relationship. Cultural knowledge, which is an understanding or knowledge of the culture, worldview, and expectations for treatment. And then cultural skills, so the ability to intervene in a manner that is culturally sensitive and culturally relevant. So that's a definition that's been provided for culturally responsive counseling. Cultural inclusiveness, something term that's been used and defined more in teaching. And so this is adapted from a way that cultural inclusiveness has been defined in teaching. And I think there are other definitions and things out there, but this is a term that sometimes seen and used without necessarily providing a definition. So I would encourage, given that this is a listening session, to talk about whether there's a better definition or a definition that we need to come to consensus on. I don't think that these are set in stone, but cultural inclusiveness has been defined as recognizing, appreciating, and capitalizing on diversity, using inclusive language, encouraging open, honest, respectful, and discouraging incivilities or microaggressions. And this is particularly important in group contexts or in settings that serve a community. It's both in the individual meetings, but also kind of more broadly in the agencies and the settings that serve these organizations. Next slide, please. So when we think about adapting, there are different reasons that we might adapt. And we'll be focusing a little bit more on cultural adaptations, but that's not that we adapt. It's important to adapt, carefully and thoughtfully when necessary. Sometimes we assume that we need to adapt and don't. Sometimes we assume that something's going to work without adapting, and it actually doesn't. So, paying close attention to why we think we might need to, and what would make it necessary, with culture in mind and with consultation and guidance. And this could come from, treatment developers, treatment, experts in the treatment, people who've had a lot of experience, people who have had experience providing the intervention or treatment to a specific community or population, and can also and should also include guidance from the community itself. I'm going to turn my camera off to see if that helps with bandwidth, to see if that stops the sound from breaking up. But we can definitely, consult our consumers and our stakeholders about ways to adapt. And so I'm going to talk a little bit about how to do that in the next couple slides. Next slide, please. So we know that adaptation is going to need to happen. And it's just a part of the implementation process. So I think what's important for us to consider is that if we view local adaptations or cultural adaptation or other efforts to improve fit as flaws in implementation fidelity, we're missing an opportunity to learn something about how we can refine or optimize the treatment at best. So at best, it's a missed opportunity, but at worst, it's a recipe for implementation failure. If we don't adapt, we could be missing really critical things. Now, this doesn't mean, like I said, you don't have to presume or assume that how you're going to need to adapt, or that you're going to need to adapt everything about it. But if you don't adapt when you see the need because you're so worried about preserving intervention fidelity, then you're going to have probably less of an impact than you would like. Next slide, please. So that said, there can be a tension between fidelity and adaptation. And what we need to think about is, how do we make sure that we are providing the intervention the way that it was designed to preserve what's conceptually or empirically important about the treatment, what makes it the treatment that it is, and more importantly, what makes it effective. So in the next couple of slides, we'll talk about how to do that. Next slide, please. Okay. So this is just a way of thinking about, we have an intervention, and we might need to modify it. So there are modifications. These are just any changes that you make, improvising, You get thrown a curveball, you make a change. A subset of modification is really adaptation. And this is where we are planning, one slide back, please. Where we're planning, that arrow where it says planned, ideally data-driven, should be pointed to the adaptation, that green circle. So adaptation is sort of a subset of modification that ideally is data-driven in some way, whether quantitative or qualitative data about fit, about effectiveness, but that we're sort of thoughtful and planful about it, to really try to make it fit as well as possible. When we do that, we can make sure that they are fidelity consistent so that they're still preserving these core aspects of the protocol. But then sometimes they're fidelity inconsistent, just meaning that they depart from the intervention the way it was designed in some way. And the next slide. So a way to think about kind of making sure that we're preserving the effective components of the intervention is to think about core elements versus core functions. So basically what this means is you want to think about the function behind what you're doing in the intervention and preserve that function or goal, even if you play with the way that it's delivered or provided. So, you might have an element that is psychoeducation. The function of psychoeducation is to help the consumer or the client understand some important things about the problem, the treatment. It might be to help them understand why you're going to be kind of encouraging them to do what they would need to do during the treatment. It might help them understand the problem a little bit better. And when you do this, it can take different forms. It could take the form of a handout. It could take the form of group education. It could take the form of watching a video and then discussing it with the therapist. It could take the form of the therapist having a conversation. What matters is that that information is provided in a way that the consumer or client can understand it, that it can resonate for them, and that they can really, understand what they need to about the problem and the treatment. So when we're adapting, we think about core functions, whatever the form it might take. This means you might be able to adapt worksheets to make them simpler. You can adapt analogies. You can adapt a lot of things as long as you're preserving the function. And it's meeting the kind of end goal of that component or that element of the intervention. Next slide, please. So as I mentioned, core elements are the parts of the intervention that are empirically or theoretically associated with the desired outcomes or impact. So in other words, they're what make it effective. They're the necessary parts of the intervention. And so when we attend to function rather than form, that gives us more flexibility. What makes the intervention effective and what's necessary might not be the same in all contexts. You could have, you could be working with people who have gone on the internet and learned every single thing that they can about the problem. They have researched the treatment. They have figured out exactly what they want, what they think will be a good fit for themselves or their child or their loved one. And so they know all about how it works, et cetera. They might not need the education piece in the same way. You might abbreviate it for them and make sure that you have a shared understanding. Whereas for other people or for other populations, it might be a bit of a paradigm shift. It might be something they don't know as much about. And there you might need to really preserve, that function and really attend to the psychoeducation piece. So, one of the things we might learn is what is and what's not necessary and effective in different contexts. Next slide, please. So when we're adapting, it can be useful to think about, ideally, we're staying in this upper right quadrant, right? We're staying in this theoretically optimal. You're planning your adaptations and they are preserving those kind of core functions of the intervention. Now, sometimes we get thrown a curveball and we are not able to do every aspect of the intervention, or we have to make some changes. When we're thrown a curveball and we're dealing with unplanned adaptations, these are things that, at the outset, you don't know that you're going to need to do. Ideally, we'd stay in the lower right quadrant, right, where we're remaining fidelity consistent. Sometimes we have unavoidable challenges, lower left, where we're fidelity inconsistent and unplanned. So let me give you an example. During COVID, everybody had to switch to telehealth. And some of these interventions were dealing with worksheets. An unplanned fidelity consistent adaptation, or let me start with the unplanned fidelity inconsistent, might be you dropped all components of the treatment that had anything to do with a worksheet because you couldn't figure out how to deal with it over telehealth, right? So you just said, we're going to stop doing worksheets. Now, you might have been dropping core functions of the intervention because now people weren't getting the practice at the new skill. And so it would be fidelity inconsistent. Over on the lower right side, though, there might be a way to do it that is fidelity consistent. For example, if you're dealing with in a cognitive behavioral therapy, cognitive restructuring, instead of a worksheet, if you teach someone catch, check, change, you're preserving the core function where they are still going through the process of catching their thought, checking their thought, and seeing if it's true, if it's helpful, if there are other perspectives, and then making the change that's most best reflects their reality and is most helpful for them. So if you do that, you're being fidelity consistent. You're preserving that core function of helping people use and practice that skill. If you drop that skill altogether, it could be fidelity inconsistent. Now, whenever you end up on this left-hand side, if you're really tracking how are we adapting and what kind of outcomes are we getting, then you have opportunities for learning. Maybe we actually find out that for some particular population or for a segment of a population, you don't actually need this thing. You can still get just as good outcomes without it. For others, we might learn that when we dropped it, people didn't do as well. So we're learning, possibly refining, or learning, how far we can bend the treatment without breaking it. Next slide, please. This is a very fancy way of saying when we're adapting, we want to first, up here at the top, we want to figure out what makes us think we're going to need to adapt. If we have a reason, whether it's stakeholder input or some data or a needs assessment that tells us we need to adapt, we want to find out, can we preserve these core elements or functions? If we can't, we want to pilot the change before we roll it out and tell everybody, drop all the worksheets. We want to pilot and see how it goes if we can. If we're not able to, if we don't have that kind of time frame, we want to evaluate closely so that we can learn as fast as possible. When we dropped the worksheets, it wasn't working. We got to go back to the drawing board. Or you know what, we dropped the worksheets, it worked just fine. So pilot when we can. If we can't, at least evaluate. And then think of it as an iterative process where you're taking, the outcomes as you're tracking and evaluating, you're taking it back to your stakeholders and you're looking down here at box E, that we're looking at whether or not the outcomes that we're interested in, whether it's engagement, symptom change, functioning, access, whether they're what we hope they are. If they're not, are they good enough? Are they good enough, where you can say, well, if we do it this way, we can get the treatment to more people. It might not work quite as well, but more people can benefit on the whole. Or are we saying, nope, this isn't acceptable. We've got to figure out a way to make it more effective. And then, we keep refining. Or we decide this treatment's not really going to fit here. If we can't do it in its adapted form and have it be as effective as we want, we might need to figure out something else. Next slide, please. Okay, so now we have a poll. So if you can go over to the polling part of the website, or the polling website, The question is, how familiar are you with the term evidence-based? Oh, nope, that was the last one. What are the challenges of culturally adapting or being culturally responsive while doing an evidence-based practice? So as people are kind of thinking about this and typing into the poll, we'll be sort of hearing from you. What are some of the challenges that you find? So when we think about these, these processes, these tensions between fidelity and adaptation, thinking about how to make an intervention fit, what are some of the challenges that you all see? And I know, especially for people who are texting instead of using the desktop, it might take a second to type in those responses. Some things are popping up though. Cultural knowledge, cultural groups are not homogeneous. Absolutely, you can't assume that you're going to make a change and it's going to work for everyone from a particular population. So many other things can matter: level of acculturation, degree to which people identify with that particular culture versus maybe other cultures or groups, or spiritual practices, etc. Making it relatable depending on the age to a younger audience. Dealing with fidelity, right? How complex it can be to maintain fidelity while making these adaptations. Finding the right evidence-based practice that can be adapted, or that, a program or practice for whatever the issue is that you're wanting to work with. And yeah, some evidence-based practices were developed and tested with more homogeneous populations than others, not getting support in the adaptation process or effort. Absolutely making sure that the adaptations don't have negative effects. So, one of the things that can happen is you can have a self-fulfilling prophecy where people say, you know what, it's not going to work with this population, so we need to adapt. You adapt, but maybe you adapt and you do sort of remove or fundamentally change one of the effective elements. And then it doesn't actually work. And you say, you see, it doesn't really work. The treatment doesn't work with this population. We need to adapt more. And then pretty soon, too many of those important elements of the treatment are changed, and it's not as effective. Now, other times you can adapt and it can work just as well or better. Understanding the information, thinking about the stigma and addressing that, and just being able to kind of address those things. Cultural biases. Sometimes people don't fit neatly into, one particular culture. And, we're really working about, thinking about blending of different cultures in a way that's very, very democratic. Thinking about how much you need to design EBPs to be culturally responsive. Can you sort of conceptualize the treatment in a way that addresses some of these individual needs? Variation within what might be seen as a broader culture, and making assumptions about that, not understanding the nuances, absolutely getting adequate community input. These are some great, really great responses that people are putting out there that really do kind of capture some of the complexity. Funding for adaptation, having the time to really do a thoughtful process, ethnocentrism, sorry. Not incorporating decolonial or anti-oppressive paradigms, absolutely. Centering the dominant paradigm, being sensitive to consumer feedback. Yeah, these are some really helpful thoughts. And thank you for so many of you for chiming in about this. And I know I didn't get to everything, but we can see some of the different challenges and some of the different things that we're seeing that that really are important considerations, important nuances, and important, really key and central issues and challenges when we're doing evidence-based practices. And how do we hold all of these things? How do we attend to these things and, figure out how to preserve the pieces that do still apply, the pieces that are and can still be helpful and effective, while attending to all of these other important elements. And this is where, getting the stakeholder input is really, really, really critical. So let me move along. Pressures from payers to use them and not understanding the need for adaptation, absolutely got to bring them along. They're stakeholders too, so having them involved in the process, but not having them be the only ones makes sense. So if we go to the next slide, I want to show you one example of an EBP, a couple examples briefly, of EBPs that have been adapted successfully. This was a couple papers were written. One was an evaluation and one was a description, adapting cognitive processing therapy for Bosnian refugees. So they'd come to the United States. About 2/3 have been tortured and experienced war-related traumas. The treatment was delivered through interpreters. They were translators, but not cultural brokers. They had to lengthen the sessions. They could do it in home. They considered the cultural context. They really integrated the importance of dealing with issues like grief and acculturation, resettlement within the cognitive behavioral framework. They added some things. They thought about how to do the impact statement and the trauma account. And they added some things, exposure to address fears of going out. It wasn't safe where people had lived before and needed to, do both cognitive restructuring and some exposure. So that's one example where they had nice outcomes. They made these adaptations and they were able to use the treatment successfully and saw improvements in both PTSD symptoms and functioning for this group of folks that they worked with. Next slide, please. This is a more recent study of CPT adapted for Native American women who abused alcohol or used alcohol use disorder. And it had higher HIV sexual risk behaviors. So they had a community advisory board with really key stakeholders, people from the community. They removed the jargon, they made it more readable, they adapted the concepts and all the definitions and handouts. They added a pre-session to promote engagement. They added some content to deal with really key issues for this particular group of women. They changed the way that they thought about, stuck points became unhelpful thoughts, talked about balancing thoughts and emotion, and some of the concepts in CPT were changed to things like respecting and caring and intimacy. And they added a closing ceremony because that was important. The next slide, the punchline is that they saw, I think on the next slide, we've got, the punchline really is that they saw some nice changes compared to their control around changes in PTSD, alcohol use, and high-risk sexual behaviors. It outperformed the wait list. They haven't compared it to another treatment. But this was a place where getting a lot of input at the outset really did help them develop this in a way that resonated with the people that they were working with. And next slide. I think that might be it for me. Yes.
Thank you so much, Shannon. This was fantastic at this point, setting up the stage for us. And I think one of the really big takes away for us as we keep in mind and have this conversation is the importance of really presenting the preserving the core elements of an evidence-based practice and perhaps adapting the core functions. So in interest of time, I think we're going to move over to our next panelist, Alfredo Serrato, who is actually one of the members of our cultural responsiveness group. Any questions that were related to this session will be addressing at the end of Alfredo's session. Alfredo, next slide, please. I want to welcome Alfredo Serrato. He is the Senior Cultural Workforce Development Officer at the Great Lakes Technology Transfer Center, and he manages the Center for Health Enhancement Systems at the University of Wisconsin-Madison. He is a national certified training on culture, an integral part of mental health services. He has been part of the National Hispanic and Latino Mental Health Technology Transfer Center in Puerto Rico. And he's also national training for the National Association for Alcoholism and Drug Abuse Counselor. He has 25 years of international relations experience and specializes in cross-cultural communications, conflict resolution, processing problem topics. Alfredo is also a member, as I mentioned, of our group, and he started this process when we first created the initial chart that I mentioned to you all at the beginning of the session. He was one of the work with others of the group as well. We are unfortunately missing today Diana Padilla, who is a project manager at the New York State Psychiatric Institute at Columbia University Medical Center. She had a last minute conflict, but she will be advising and continue to working with us in all the materials that we're compiling together in this conversation. So Alfredo, we're looking forward to your session. So we talk about the importance of the CLAS standards.
Maria, thank you very much. I think we're going to be starting off with a poll, if that's right. Jessica's going to pull that up.
Yes, everyone, please get ready to participate in our next poll. We wanted Alfredo to start his session with an idea of how many of you are familiar with the CLAS standards, also known as the culturally and linguistically appropriate services standards. We can go to that next slide and we'll officially launch the poll. Again, we have the instructions in the chat box for you if you want to join via text or via web browser. Okay, well, this is helpful, right, Alfredo? You get to see who we have in the audience, those who are not familiar at all with the CLAS standards, and we have a few that are very familiar. So good range there, good diversity.
Right, yes. This is incredibly helpful because it allows me to either go a little bit into detail. And also, the one thing I want to mention, Jessica, just for everybody's sake, is that we will be providing a lot of resource material to the group. And so if I do not cover something today because of time, we will definitely come back and provide this material to you either via email or via the chat. There is one document that I want to share with you, and Jessica is going to share that document, at least the link for it, so that you can get the CLAS standards for yourself. And it's over 100 pages. It might be good to view this in digital form, but if you are very interested in this particular platform or framework, I would suggest printing it and getting familiar with it. I can see that there's quite a few of you that are not familiar with it. So I'll get started and start sharing, and maybe in the middle of it, or even during the question and answer period, you can ask more specific questions if I do not get to a particular thought that you may have. And so let's go on to the next slide, Jessica, just for time's sake. So this is actually going to be my only slide, and I'm going to be talking briefly on all these points. The National CLAS Standards, they have a particular intent, and that intent is to advance health equity, improve quality, and help eliminate healthcare disparities by establishing a blueprint. And that's the key word for the CLAS Standards, that it is a blueprint. It's not going to give you specific examples, although the good news is that some folks have already taken the blueprint and developed enough of it that it does. There are many documents out there that actually give you very specifics of what can be done in a particular field. Now, the focus of the CLAS Standards is to advance health equity, improve quality of care, and help eliminate health disparities. That's the focus of it. And so what I do want to say about this is that there are 4 settings that the committee that developed these standards had. And the first setting is ambulatory care. So if you walk in and out of a particular practice, this is something that they had in mind. Hospital settings is the second. Public health is the third. And then behavioral health, our field, was the fourth setting that was developed by them. And so the intentions of the entire 15 standards is focused on these 4 settings. And so today I'm going to be focusing on the last, which is behavioral health, just because that's what we're all about, and give you an overall perspective on how that can be applied and what we can do in order to kind of facilitate some of the applications that CLAS can actually offer. And so, and I'll start off with a little bit of history. The CLAS standards actually got started in the year 2000. And so today we have what we call the enhanced CLAS standards, because there was an adaptation of those standards in 2013. However, in 2003, there were 2 reports that came out. The 2 reports are the specific to, hold on one second, let me grab that. They were specific to HHS, and they pointed out the disparities that were already in place. And there was also an inequality report that was put out. Those 2 reports in 2003 actually became the catalyst for making CLAS standards a little bit more relevant to work in those particular 4 fields that I mentioned earlier. And so, and the one thing I want to mention about the CLAS standards is that the language that is used there is used from 2013. So it hasn't necessarily caught up to the language we use today. It doesn't necessarily use responsive as a word. It uses more, the language that it uses is more competency. And a lot of folks are not necessarily in favor of that particular word. But my colleague, who's not here today, she actually did a training, and she used the word competency not as a noun, but as a verb. And I just love that idea for us to be able to take what was developed and actually make it more active. And so the idea behind this is to get us to a point where we can start thinking culturally and be able to apply some of the things that are I think more difficult to understand. And culture, unfortunately, is one of them for the US. We have not thought that historically, but now we're starting to do that. And so what happened was they developed 4 parts to the CLAS standards. The first one was the principal standard. And that standard is the one that everything is driven to. It is something that we focus on as if we develop any of the other standards, it is actually fulfilling that first standard. And let me read this to you. It says, the principal standard is to help understand the essential goals of 3 themes. One is, the first theme is governance, leadership, and workforce. The second theme is communication and language assistance. And the third theme is engagement and continuous improvement and accountability. And so they wrap all this up in that first standard. And then the other 3, as they're being fulfilled, they are focusing on making sure that we're all fulfilling that first one. Now, the first one, just to give you a part of the structure, is governance, leadership, and workforce, like I mentioned. And so in general terms, we need to be able to have a buy-in. And so influencing your governance systems and your leadership is key. And also getting a buy-in from the workforce. And so that basically all has to do with human resource. And it's hard on both ends, just to let you know. The governance piece is difficult if you happen to be a change agent that is not in leadership already. And unfortunately, a lot of the people that we actually end up training are in middle management or below. And so the leadership is not necessarily coming to the table for this kind of training. And that's something that we need to facilitate and change. The workforce, the issue with that is related to more of a recruitment and retention piece. It's a lot of folks do not look like the people that they're serving. And so therefore they're having difficulty serving them because they do not necessarily, one, they may not be trained for that particular culture, or they may not have the staffing that represents that culture. And so that's a theme that in order to get started in class standards, I think you have to first deal with that particular theme before you go on to the next two. And so when I do training on this, I usually tell folks that not to get overwhelmed with the class standards because there's quite a bit. In the studies that we've done, there's literally over 500 pages of examples and categories that you need to study in order to implement these. However, I encourage people to start with one thing, and that one thing is buy-in, and that is very critical for theme one. Then we go after that, go into theme two, which is communication and language assistance. Now, this particular piece has a lot to do with the infrastructure. If the organizations that are trying to fulfill this particular standard do not have a good infrastructure in order to be able to reach the community, or even more so, invite the community in, there will be a whole lot of difficulty. And we've seen a lot of this with COVID. COVID-19 has shown us that we need to be ready. And the good part is that COVID has actually helped us in this particular area, because we are now getting a lot more computer friendly and being able to access systems that may be outside of our particular organization. And so that's a very good thing. And then the third theme is engagement and continuous improvement. And the whole thing about this particular theme is that we need to keep everyone accountable. And so it brings it to the personal level. As a particular staff, or as a board member, or as the executive director of the organization, am I fulfilling my duties in the overall scheme and structure and of class as we're trying to implement these? And so continuous improvement and accountability are key to this particular theme. So I want to give you those particular structures because I think it's key for you to be able to understand it once you read it. And again, we put the link in your chat so that you are able to read it for yourself. And the whole point of us bringing up class standards for this particular session is that as you look at all these evidence-based practices and community-defined practices, you're going to have to think in class terms in order to be able to implement these. And so we found it as a group to be critical on the fact that class standards is a necessity, and it can have a huge impact in what we do. And so just to give you an idea of the type of impact that this is already having, there are 10 states in the entire US that are now mandating class training for their particular state. And there's another 11 that are proposing a mandate for these trainings. So that's already 21 of these states that are very interested in the class standards as a footprint, as in order for them to be able to do good work in relation to culture and language. Now, again, there's 31 additional states that do not have this. However, that does not mean that they're not doing training on culture and linguistics. But I would say, I would make the argument for us to be able to have an impact with class standards, more and more states need to adopt and practice what the standards relay. And so, and then the last piece is the ethical, business, and legal case. Now, there's quite a bit here in terms of us being able to look at class standards in a way that we can respond to demographics. As an example, the immigrant population is changing on a regular basis. And so we need to be, as a workforce, be ready for those changes. So there is an ethical piece behind that, that in order for us to meet the need, we need to be ready. There's just the general sense that we need to be able to eliminate disparities. COVID-19 again is shining a light on all these disparities. And for us to be able to fight those disparities, we need to put a system in place. And I consistently make the argument that in order for us to fight systemic and structural issues with social justice, that we need to fight it with systems and structural change, and not necessarily be pointing fingers at people, but rather the systems and the structures themselves. And so I would make a case that that is a very good path to take if you are an organization that's interested in CLAS. Now, we can also use CLAS to meet legislative demands and mandates, accreditation mandates. We can also gain a competitive edge. And that's something that I think when I do the trainings that organizations tend to miss, is that the better prepared we are to receive all sorts of people into our midst, the more competitive we're going to be in the marketplace. They're going to come to us instead. And so there is a business case behind that, I think. And so, and there's also a mitigation of liability piece. The more your staff is trained on treating people from all these different cultures, the better prepared you are to mitigate the liability that comes from mistreating people out of even a mistake that's been made by one of your staff members. And so I want to give you that particular holistic approach of what CLAS can do. And I will open it up now to another poll question that Jessica is going to pull up so that we can get to the question and answer period. And I'll be looking at these questions that you are providing now and see if we can get a conversation going. So Maria and Jessica, I'll turn it over to you guys.
Great, thank you so much, Alfredo. I know that it's so hard to pack everything into a short period of time. And I know we're sharing the stage today with Shannon, and we also want to encourage our audience to continue to plug in any questions you may have in the question and answer pod. Again, we're trying to have some time before the end of today's session to respond to those questions. But in case we don't get to those, we are putting together an FAQ document that will include any questions that we didn't respond to live today. And Alfredo and Shannon will be providing written responses to those, along with any resources that we've shared today. So you'll be getting that document within a week. Let's see here. We want to make sure that we launch this poll. And so Gabrielle, if you don't mind, we'll go ahead and get that up there. I will put in the instructions again in the chat box for those of you who want to log back into the window or text. You have the question there. How do the CLAS standards need to inform any evidence-based or community-defined practice? Please share your thoughts with us, and Alfredo will help us engage.
And just to, Jessica, just to let everybody know, I went quickly through the standards just because I know that we had an issue with time, and I want to be able to give everyone an opportunity to ask questions. So I did a broad overview. However, I know that we're going to get deeper into the subject as the questions appear and as people give a lot of their perspective on how CLAS can influence evidence-based practices and community-defined practices as we are looking at them through this series. So it says, seems like basic common sense. You know, that is, that's one of the comments that was just put up. And I would say yes, but when you start trying to practice CLAS standards, you suddenly realize that it's really very systemic, and culture, you know, as a whole is incredibly systematic. And so when I study culture, I see all the differences, and I start analyzing all the different steps that they're taking in order to be able to get to an end goal. And I'll give you an example of that for the person that wrote that particular comment, is that in the US, as an example, we tend to say, for an apology as an example, we tend to say sorry, and that ends the conversation, right? But in most other cultures, it's a three-step process where you actually have to have a sense of being sorry, and then reciprocity, allowing for forgiveness to happen, and then reparation. And so all these cultural pieces, although they seem to be common sense, unless you line them up somehow and in an outline, it becomes incredibly difficult. So I'll read, validate that there's community-based practice instead of only EBP. Yes, and I think that the more we apply CLAS, the better that light will shine upon that very fact, in that CLAS will help everyone in each of the states that I mentioned. Those particular systems will suddenly realize that that we do need community for them to give us the answer. And I spoke with a friend the other day about motivational interviewing, which is one of the topics that we're going to be covering in this series. And it's like macro motivational interviewing. We have to go out into the community, and for the most part, they will give us the answer of what they need. And so that's a very cultural piece. And CLAS actually help us towards that in the application of these. So again, helpful tool, effective communication, care, personal life in general, by providing process engagement, continuous improvement, and accountability. Yes. I would suggest that people developing EBT programs use CLAS standards while creating education programs. Yes, and one of the things that I would say is that if you have CLAS as a blueprint, you can actually extrapolate any program onto that blueprint, and you can start designing programming that is actually at the core very culturally and linguistically sound. And so one of the things that I imagine when the CLAS standards are expressed as a blueprint, I imagine the foundation of a home. You know, you have this blueprint that gives you the how to put this foundation in, but then you come to the design part, right? And that's the beauty of it. As an organization, you can look a bunch of different ways. And so the types of windows, the roof, the plumbing, all these things are really up to the organization. However, if you have this foundational piece, which is CLAS, I feel that you're in a very good spot. And so, and then I'm gonna allow Shannon to chime in some of these, because they're very specific to evidence-based. So Shannon, if you have any comments on these, I will welcome your input as well.
Yeah, I mean, I think, you know, one of the big things that we sort of wrestle with in this broad field is what we mean by evidence, right? And what kind of evidence we privilege, and thresholds around evidence. So when we talk about evidence-based, you know, expanding and considering that definition, and having a way of doing it to make evidence as inclusive as possible while still recognizing the need to evaluate that it's working and how we know it's working. What are we attending to? I mean, I think that those are important things to consider when we talk about evidence-based practice, especially in relation to, to standards like this. And I think it challenges us to broaden the perspective while still sort of keeping this this North Star of improving people's lives, right? So, I hope that for this listening tour, that this is a place where, we get input and really good thinking about how to balance these types of things. So, developing culturally specific EBPs, do we start with an EBP and adapt it? Or do we start with do we center the culture and build something that can work and test it? And what do we do based on our timeline, other needs of the community, resources, et cetera? And there are a lot of tensions that sort of pull between some of these different things, some of these different factors, right? Is if we do develop culturally specific EBPs, starting point.
Well, thank you both. Alfredo, thank you so much. Unfortunately, we're not going to have time to really go over each comment, but as we said before, we're going to be compiling everything. And we now need to really move to the last session, which is really, really important and has been a big priority for our group. And I'm going to invite both Alfredo and Shannon to stay here, and we're going to combine it with some questions. So let's please go back to the community-defined evidence slide. Because clearly, as we, from the beginning, when we set up the stage, and if we can move it to the next slide, please, we have a definition and we understand this dilemma. So as Shannon was just responding and Alfredo was just describing how we do this, how we merge this, and we know that just to put up the definition again, some of these practices, we know that communities are using them. They have found that they are very positive, and they are determined by them. There's some consensus over them. And this practice may or not have been measured, but it's really important for us when we think about these issues, how we then work with this and how we also equally provide importance and how we consider this very important question. So to do that, we're going to break out into our question and answers session, and our co-chair Christina is going to be leading this. With that, I think, Jessica, I'm going to turn it over to you. There's a poll, two more polls that we need to answer before we get into the discussion. So go ahead, please.
Yeah, so again, everyone, please get ready to participate via poll everywhere. We have Shannon and Alfredo still with us here to respond and engage with the next two polls. So if we can go to the next slide and get that launched, that would be great. So based on the information shared today by Alfredo and Shannon, please share with us the community values and perspectives that you think should inform any practice, including evidence-based practices and community-defined practices. And as we see some responses pop up on the screen, Shannon and Alfredo will share a little bit more their thoughts about comments that we're getting in. Let's see, let me try to put in the information for joining into poll everywhere again on the chat box here.
Jessica, someone put in family, and as we do the training on CLAS, one of the examples we use is when there's a child that has to translate for their mother, and the doctor's telling the mother that, as an example, that she has cancer, and then the child is the first to hear that in order to translate that to the mother. Issues like that are big, and in terms of relation to family that really affect children in a big way. And so I really like the fact that family was the first input from everyone, because I think that that's an impact that is not necessarily considered on a regular basis when putting any practice into play.
Shannon, any comments? Anything you would like to comment?
Yeah, you know, I think that really about, you know, these things that are really key values, you know, relationships, certain traditions, you know, understanding how to sort of fit in terms of speech patterns. You know, some people, you know, might have a more circular way of thinking and relating that may not fit an EBP that was developed to be super linear. And so adapting is really critical to ensure that people understand, I mean, that we are, but to have that kind of a fit. And, you know, so they're really thinking about worldview, values, you know, the way that people relate can be really critical. And it's not an all or none. It's really a how can we. And so I think that not just having a bunch of people who have even, you know, have done the treatment before with particular cultures, certainly that's critical, or the people who develop the treatment, but also people from that community who can provide those perspectives and share their reactions is really so important when we are adapting, because there might be things that we just miss if we don't have that perspective. And, you know, and it might be longer sessions, slower sessions, you know, things that really are important for a community. And so it's a how can, not a can we question, and getting the right people at the table to answer that question is really critical.
Thank you so much, both of you. So I want to make sure we can have time to go to our next question, so we can then go turn it over to Christina to answer any final questions and wrap it up and learn about what's next. So Jessica?
Yeah, so we have our last poll here. Do you use any culturally defined, culturally adapted, or community developed practices? And if so, please share the name and the population that it was designed for. We're really interested in, again, getting to know our audience, and this will really help inform us in our upcoming sessions that will be truly focused on specific evidence-based community-defined practices. So we're seeing a lot of no's.
Jessica, that's, you know, and I know that a lot of people would maybe consider all these no's as something that is a negative, but when it comes to the CLAS standards, that's actually, and if you were to do an assessment of your organization or your school district, whatever the case may be, on CLAS, it would give you the evidence that there's nothing there. In order for you to be able to use that as a buy-in point for your leadership. And if you use the numbers in terms of population of the people that you're serving, compared to the evidence of what's not there, that would be, I think, a very good assessment in order to prove the point if you happen to be a change agent in CLAS. And so, and that will open the door for evidence-based practices once that is documented. And so I just want to encourage those of you that are saying no at this point to continue with this series, because it will allow you to gain perspective on how the adaptations and how the different community dynamics can also influence your particular work. And so I know that it's actually quite a bit discouraging to see that, but I have to be able to turn that around and say that that is probably the best case for the majority of the people in the audience to be able to get CLAS and evidence-based practices into their particular arena.
I'm seeing wonderful examples. I just see one on the Nepalese case managers working with Nepali clients, gay affirmative therapy, Hispanic Latino talk about soul sickness. So there's a lot of great resources that people are commenting. Shannon, do you have a comment?
Yeah, I think, I mean, it's nice to see, people are starting to, share some of the different practices that they are using, that they're aware of, and as well as some of the culturally adapted, practices. And, I think that some of what we see in, but probably not enough of it is, when we do research on adapting evidence-based practices, there is some integration of community defined practices that are really key. So how do we, honor and respect traditions and perspectives and, and key values while, bringing in these other elements? How do we integrate in a way that doesn't water down either, and where they can really be synergistic, I think is critical when you're thinking about using EBPs and integrating with culturally defined practices. And then I also think, I wonder too, the goals of the culturally defined practices can be really critical too. And a lot of times, they might not be, the same goals that we have for EBPs, to reduce symptoms of post-traumatic stress disorder, might be very different from what a culturally defined practice is doing. And that, paying attention to what the goals and what the purposes behind each can be really important, and can give us some clues about whether and when and how even to integrate and, use these two things as complements when appropriate.